a whole community. This is our 39th monthly meeting. So hopefully we can continue doing this. Please feel free to give feedback to what topics you would like to do. Good evening, everybody. Yeah, good evening, Dr. Rupanjana. What topics you would like to see here? So we are trying to see how we can together study various aspects of neuromuscular disorders, even if, say, for example, it's in the field of neurophysiology, it's in the field of diagnostics, or in the field of basic science, which takes the whole field forward, or allied fields, or other fields. So, for example, cardiology is very much a part of this. Many of our children with neuromuscular disorders have cardiac conditions. Invariably, most of them end up needing having respiratory problems. So these are the various aspects. So we have talks from all these other specialists. Also, people like Ms. Mahima play a key role, because most of these children, we are talking about improving quality of care for our children and young people affected by these disorders. So people like Mahima make a huge difference, because their weakness, we are struggling to keep up with the weakness, and many times we don't have diseases to, we don't have any means to control it, but then they end up, the weakness leads to deformities. They try and see if they can make sure that deformity does not become too much, or in some cases, even try to prevent it. So welcome, Sureka madam. So Dr. Sureka is also here. I'm just waiting for the 5-minute cutoff. So, okay, so we are 5 minutes into it. So we don't have a moderator, because basically this is a catch up. So we had we all had a great time at Vienna. There were lots of new things that happened. And thank you, Dr. Anna. Dr. Anna has been inviting everybody. She was also part of this. Feel free. This is an informal meeting. Feel free to comment, but preferably we comment at the end of the talk. Some housekeeping rules. ORDI is the chair for this. Thank you to ORDI for hosting this and continuing to host this. This is the 4th year running where we are trying to encourage neuromuscular to be encouraged as a subspecialty within our country and neighboring country in this region. So our first speaker for the day is Ms. Mahima.
Yes, ma'am.
Ms. Mahima, are you ready to be the first speaker?
Yes.
Okay. So, sorry, just 1 second. What is Ramya talking? Ramya is talking about? She's talking about muscle MRI. No, it might be better. Sorry, Mahima, it might be better if Dr. Himashweta speaks first, because she's speaking clinical. So if she speaks, then between the two of you, and then you intersperse. So, Dr. Himashweta, would you mind being the first speaker?
Not at all, ma'am.
Sure. Please carry on. Sure. Thank you. Thank you, Dr. Himashweta, Dr. Mahima, and Dr. Ramya for agreeing to be doing this. On to you.
Uh, 39, we have WMS 2025 updates, and what I'm going to talk about is cardiomyopathy in DMD and the changes in the treatment paradigm. Most of the talk by Dr. Khan Hor from US has given an excellent talk on the current shifts in the management of cardiomyopathy, and I have taken a little bit of the data from the recent 2025 guidelines for the management of cardiomyopathy in DMD. So a little bit of background on why dystrophin is as a channel, as a membrane stress, because of the dystrophin glycoprotein that plays an important part in maintaining the extracellular matrix cytoskeleton. And the function of dystrophin is to act as a shock absorber for transmit forces when the contraction dystrophin is affected, the sarcolemma membrane fragility occurs. There is substantial damage to the extracellular matrix cytoskeleton, and as a result of which there are micro tears in the membrane. How that impacts is what we are going to talk about. So DMD pathophysiology and inflammatory cascade. As a result of dystrophin deficiency, there is a disruption in the dystrophin glycoprotein complex, and which results in an increased permeability of sarcolemma, which in turn results in higher intracellular calcium concentration. In the animal models as well, it has been confirmed that because of the calcium dependent proteases and chemokines and cytokines, the spectrum results in a sort of an inflammatory cascade, which in turn gives rise to infiltration of inflammatory cells, muscle degeneration, fibrosis, muscle necrosis, impaired regeneration, altered autophagy, and insufficient angiogenesis. This is not just in the skeletal muscles, but as Dr. Ann will also expand further, they are multisystemic disorders. So there are most of the changes, although they are in the motor aspect and the muscle aspect, we would be focusing more on the cardiological aspect of it. So heart failure, although progressive in DMD, is remaining silent because by the traditional definition of heart failure by the NYHA and the AHA, the adult signs of heart failure are always presumed to be chest pain, shortness of breath, and the edema. However, in patients of DMD, these symptoms are, even at advanced stages, they are quite vague, and because of the motor aspect taking the front seat and the loss of ambulation, these symptoms become even more difficult to pick up. However, although they are manageable, but early diagnosis, according to the recent guidelines, is paramount in the importance of it. So if we pick it up early, it would be better to treat it if picked up early by preventative measures. So these are one of the few main aspects of the talk that we should be highlighting upon. So now, because of the improved in the respiratory management of DMD, the cause of death has shifted more towards the acute cardiac causes due to fibrosis and dilated cardiomyopathy. Initially, it was presumed, it was considered to be cardiopulmonary failure, but now it has shifted to more acute cardiac causes, with case reports being reported about myocardial infarction and sudden death as early as 6 years of age. So preclinical signs such as ECG, GLS begin to appear much earlier and can be picked up as early as 5 years of age. And once if a scar is formed into the heart, the presence of scar causes reduction of left ventricular ejection fraction from 0.2% to 2.2% per year, which is around 10 times increase, and it is significant enough to warrant our attention. And if we detect these problems early and intervene early, it would bring about a significant improvement in the outcome and help in the overall survival and quality of life. So how we can do that, I'll be just summarizing in a few slides. So as we all know that DMD management requires a multidisciplinary approach, and here I would be focusing on the cardiac management. The tools that we have are ECG, echo, cardiac MRI, Holter, and the aims would be to identify early and manage the progressive cardiomyopathy, the silent heart failure, cardiac insufficiency, conduction abnormalities, and arrhythmias. There are various interventions which we can use right now, are most of pharmacological intervention, and many of the medications are coming up which would be multisystemic in and mitochondrial in approach, or more simpler molecules are being looked forward to. But right now, this is what we have at present. And echo, although the traditional structural echo is not very useful, the advanced techniques are much more useful in picking up these early changes. The most commonly used tools are FS, which we called as 2D fractional shortening, the speckle tracking echo. This is called as echo plus GLS, and this is what we use as early as 5 years of age, or as soon as we come to the diagnosis. This is the first thing that we look forward to, other than the physio assessment and the motor management. So as per the studies, it has been observed that reduced GLS was observed in around 50% of the patients with DMD with normal left ventricular ejection fraction. So as per the current studies, we feel that this reduction of GLS is estimated to be 0.34% annually, which is a big number. And this GLS correlates to some extent to cardiac MRI. However, it correlates better with the circumferential strain and LGE. Newer guidelines now recommend that CMRI or cardiac MRI should be intervened and used much early, but in a resource constrained environment like ours, the cardiac GLS is a very important tool, because if we do it even biannually, even subtle changes if picked up, it helps us to intervene much early with medications. There are some limitations of echo GLS, although they are that it cannot detect tissue specific changes like fibrosis, and there is some sensitivity issues, that it is much more sensitive, and sometimes in 37% of the patients it is difficult to visualize some segmental defect, and there is inter-observer variability while measuring the GLS. However, at present, where we have majority of our centers in our country which have mostly structural echo to screen, GLS is a very important additional tool which is very important. Cardiac MRI is currently being hailed as the new and better sensitive tool, as it is non-invasive. It provides accurate volumetric measurements, assessment of wall motion abnormality in real time, and there is no negative effect of radiation, plus excellent reproducibility. There is no inter-observer variability, because of which it is the chosen tool in cases of clinical trials where it can be used as a surrogate outcome measures in the upcoming trial. It can, the most important aspect in the cardiac MRI that we are looking at is late gadolinium enhancement, which we call as LGE. In many of the studies that are upcoming, this LGE is actually the delay in the washout from some of the tissues. In cases of DMD, the deposit or this washout is subepicardial and absent in the subendocardium. If this is picked up, it is picked up at a very early stage, and it can be used to escalate the treatment much early before detecting even changes in the left ventricular ejection fraction, and even before there is a presence of scar. So it correlates well with the age, and it is present in around 30% of the patients with normal LVF. In female carriers, it is interesting to know that this LGE is correlating very well with the male counterparts and giving us a picture of fibrosis that is very much similar to the children with DMD. So, although the carriers are asymptomatic, this LGE can be also picked up in the female carriers. And later on, if we think as the future guidelines will command, they will be focused more on the cardiac MRI. It can be done as early as 6 years of age. So, clinical and therapeutic implication is it helps us to intensify therapies at early stages. And there are few other upcoming techniques which are used, which do not involve a contrast also. For example, in T2 mapping, it picks up fat infiltration, edema, and inflammation within the affected muscles. However, cardiac MRI uh, is a expensive aspect, and there is limited availability. The length of the study, the sedation, and the potential for gadolinium toxicity are some of the features that we feel might limit our usage of it as on a regular basis, especially in a country like ours. And plus, the breath holding segments are essential part of cardiac MRI. In patients who have respiratory issues as well, it would be difficult. However, nowadays new techniques are coming up to replace these free breathing segments, and the breath holding segments are being changed now. Okay, a part worth mentioning is arrhythmias, because the presence of fibrotic scars in the myocardium gives rise to a predisposition for these children to have arrhythmias. And these arrhythmias are not just sinus tachycardia, although it is the most common one that we have seen. There are more serious ones such as atrial fibrillations, AV blocks, ventricular tachycardia, and ventricular fibrillations. And they have been reported in patients less than 10 years of age. These are the predominant reasons that Holter testing should be paramount as early as 5 years of age, because these are this arrhythmia is the cause for sudden deaths even at a younger age. So Management strategies, if we are looking for, first is prophylactic management. So ACE inhibitors are the predominant medications that we are using. They cause an afterload reduction, and they are shown to reduce the progression in LGE and CMRI also. The second line or the second step that we use to escalate is, on the holder, if we pick up arrhythmias, we add on beta blockers, because tachycardia is the most common arrhythmia that we are picking up. There are new biomarkers that are being evaluated for, and newer therapies such as SGLT2 inhibitors are on the rise. And even some of the guidelines in adults now recommend having SGLT2 inhibitors in left ventricular ejection fraction less than 45. So, although that is mentioned in the guidelines, still it's a long way for us to be able to use them on a regular basis. What we usually use are perindopril, we use eplerenone, and we use carvedilol. So the experience with our cohort, especially because it is important, is we usually follow the pattern of echo plus GLS as soon as the child is diagnosed. The first time that the child is diagnosed, we evaluate them for echo GLS, which is usually, for some patients, it is much later that they are diagnosed. And most of the patients of ours, they undergo biannual echo after the age of 5 years. Because we are trained to be cardiologists that do our echo GLS, there is a reduction in our interobserver variability. So there is more reliability in detecting the subtle changes, and because of which we are more aggressive in treating or acting upon the reduction in the GLS. If after intervening also, if we feel that the GLS is significantly declining, we like to correlate it with the cardiac MRI more than 7 years of age patients. And as a result of annual Holter and these biannual echo plus GLS, we are able to escalate the treatment early, and it gives a very excellent outcome in terms of uh, ejection fraction as well as reduction in the sudden deaths. Most of our patients are on 2 to 3 cardiac medications by the age of 12. And because of an excellent team in the respiratory aspect as well, we are able to intervene if the child is having sleep hypoventilation and respiratory issues. We are able to intervene early with sleep study or in early initiation of BiPAP. So together, it overall gives a better outcome. Uh, my talk is a little bit short, so I would like to end on this note. And ma'am, is that okay?
That is perfectly fine. Shall we move on to Mahima's talk?
Yeah, sure,
Otherwise,
ma'am.
we won't finish covering.
Yes. Thank you.
Mahima's got some 4 papers, some examples to share with us, which she picked from, because some of them were also, Mahima, I forgot to ask you, did you manage to get that that cough assist device ka poster? Ms. Mahima?
It's not in this presentation. It's on the other presentation.
Okay, I'll just briefly put it up in mine.
Yes.
Okay, sure. So that there's no duplication. So please go ahead, Ms. Mahima.
Good evening to one and all. I'm Mahima Paul. By profession, I'm an orthotist, and I'm currently working at Bangalore Baptist Hospital. And today I'll be discussing about the update on WMS assistive technology and rehabilitation. So today I'll be presenting you 4 papers which are related to the assistive technology and rehabilitation used in their clinical setup. So we have divided the papers into 2 categories, which is of SMA and DMD. And under SMA, I'll be discussing about the assessment tools, taping for drop hand, and in the DMD, I'll be discussing about personalized aerobic training and heart rate and ventilation during the submaximal cycling exercise. So let us discuss the first paper, which was presented by the author Bianca from the University of Pisa, Department of Developmental and Neuroscience. Italy. And this paper talks about testing cognitive development in weak infants with spinal muscular atrophy and its insights and challenges. So, author talks about the challenges they had in assessing the cognitive and developmental delay in children with SMA type 1, which was related to the fact of commonly used assessment tools includes material and items that were not suitable for the weak infants. So the main motive and aim of the study was how could we modify and how the modified material which can be used as a tool can benefit and be suitable for SMA kids. So what were the modified material used? So it was 3D printed textures which was used instead of the traditional assessment tools while maintaining the same size, shape, and color. So, as you would see in this PPT, your left hand side is the normal assessment tool, which weighted 17 grams, whereas the 3D printed one was of 5 grams, which is half, then less of the original weight, which has identical, almost identical shape and size and color. What made a difference in changing the material? So there were 11 participants in this study, and based on the study, the author says that the children with SMA with high motor impairment had a better scores when using the lower weight vision developmental scale than using a standard protocol. This gives a suggestion that a modification of assessment tools, including the reduction of weight with some adaptation to posture, could offer a better results while using a heavy assessment tools can reduce or give a lower score than using a different material and with a less weight could actually benefit in giving a better scores. And as we are talking about a 3D printing, I felt I could give an extra additional point on it, as at present 3D printing is easily available. As an example of Bangalore, there are so many centers where could help with 3D printed. Even you could use it in your clinical setup, let it be a tools or a hand splints, less weight. You can where there are different materials and could come with different colors and textures. So this is all about our first paper. And our next paper is based on neuromuscular taping for drop hand rehabilitation in an early treated infant with SMA type 1. This is the case report where the study says that the taping for SMA type 1 with born with dropped hand who received a pharmacology therapy at 20 days of life, with this taping they would able to bring a neutral wrist position while preserving the ability to perform an active movements. So the method used in the study were simple, which was taping was applied in the dorsum of hand and forearm along with the wrist extensor muscles and to restore a hand alignment while keeping in mind facilitating an active dorsiflexion. Apart from this, this taping was kept for 3 days, and post that 1 day interval, they would remove and repeat it for 3 more months. Parallelly, the parents were motivated and encouraged to do an active movements, and therapists performed a passive stretching 5 times a week. And the results were found that they were able to achieve a full range of motion, and there was no adverse effects related to the taping. And during this study, they able to find that it was helpful and they were able to help in preventing joint deformity and preserve the voluntary movement. But in other way, this taping is not replacing an orthotic splints. This is one of the way it could be an early rehabilitation, and later on, if there is still a deformity, they could go ahead with an orthotic device. As in this study, there was no sample size mentioned. I think there will be a still more investigation on this, but this was an interesting case for us to see. And this is all about this paper. I'll be going ahead with a DMD paper, which is about personalized aerobic training in Duchenne muscular dystrophy, an exploratory study to evaluate safety, feasibility, and impact on fatigue and quality of life. To give a brief background about it, it says is every individual kid is capable of doing a same exercise, or is the exercise able to handle their tolerance level? So challenges were to fixed protocol don't suit every individual tolerance, and the concerns were overexertion versus undertaking in DMD. So the aim of the study was to develop a personalized aerobic training program to evaluate feasibility, safety, and effects on fatigue and quality of life. So the study design was prospective and non-randomized exploratory study, and the participants were four, aging from 6 to 13 with DMDs, and the training type were lower and upper limb say, cycling, and the frequency were 2 sessions per week for 4 months. During this training duration, the time period of giving them exercise where time periods were increased, like say it as you could see 5 to 15 minutes, and the next month would be 8 to 15. So duration of time for exercise were increased, and the assessment used for uh, examining this for fatigue, it was 6-minute cycling test and monitoring for monthly evaluation, and the exclusion criteria were active cardiac disease, cognitive impairment, and the key results which was found in this study was all the four participants have completed the 4-month program. There was no adverse effects reported. The cycling capacity improved, and there was a reduction in fatigue. So, a message to take from this study was uh, personalized training was safe, feasible, and this improved in cycling capacity and reduction in fatigue. As though the study had very small sample size, but then still something which we could learn is this program was of 4 months. This was a long period of time, but then the motivation has been kept during all the session by using music, videos, and verbal encouragement. So from this, we could see that every kid has to be monitored properly, and every this study highlights the benefit of a individual exercise to be given to them and which could help them. This is all about this paper, and we'll be seeing our last paper, which is about heart rate and ventilation during submaximal cycling exercise as um physiology outcomes measured in Duchenne muscular dystrophy. So this study talks about the to determine whether the measurement of heart rate and ventilation during submaximal cycling exercise reveals uh, physiological limitations in ambulatory, non-ambulatory kids with compared to the healthy and age-matched control. So I was bit curious about this equipment, which is called recumbent ergometry. I have a small video which describes how it helps and what all the features are there which helped this study. So this equipment of cycling, this takes weights up to 300 kgs. It's easy positioning, electrical adjustable seat, adjustable hand grips, so that every individual can use it. And apart from that, this exercise has access to endurance and cardiovascular responses without causing any individual to feel exhausted. Apart from that, workload. When I say workload, it means the number of pedals an individual person does for a cycle. Eventually, the energy consumption is measured, and this pedaling is being measured and gradually increases. Say for per 2 minutes, the energy is increased, and eventually, if it notices that patient is not able to continue, it stops, or patient can or the person who caregivers can stop this one. And apart from that, this mission also checks the respiratory. That means the system is able to calculate the oxygen consumption and carbon dioxide production. And apart from that, heart rate monitoring is also possible. So overall, this mission is able to give a individual person a data about how every kid is able to perform, how much is their heart rate and oxygen level, and how much energy consumption is being taken in this. So I would like to say the results about it. So in the results, it shows comparing to the ambulatory, non-ambulatory, and the healthy ones. The result says the boys with DMD showed a higher heart rate and a lower oxygen uptake efficiency during the submaximal cycling exercise compared to the healthy ones. This means their cardiorespiratory system is less effective and their heartbeats were faster and their breath were more heavily for the same level of efforts. Because these measures can be recorded and non-invasively and easily, they could serve as useful indicators. So this equipments, we don't use it over here in India, but then this could be a very useful one where it can record individual persons and can be used for a better improvement for the next exercise purpose. And this is all for today's session. There are few more which I'll be talking in upcoming sessions, which is related to assistive technology and rehabilitation.
Thank you very much, Dr. Mahima. Ms. Mahima, thank you. Now, just see if Ramya has joined us. Perfect timing. So, Dr. Ramya, on to you. Would you
Can you
mind?
hear me?
Yes, you can.
Okay.
Would you mind starting your talk?
Yeah.
Introduction. Dr. Ramya was working with us, and she had finished her fellowship. She had trained in Baptist and finished her neuromuscular neurology and fellowship with us in our department. And now she's started her neuromuscular fellowship at Great Ormond Street and is working with Professor Montoni. On to you, Dr. Ramya.
Yeah. Thank you. Thank you, ma'am. So I'm just going to talk about the muscle imaging updates that we had from WMS. This is from one of the pre-teaching Congress workshop. Yeah. So most of us know muscle MRI and we are using it commonly now. So just I'm going to touch upon the common sequences that we use in muscle MRI. So to make out muscle necrosis or inflammation, we use water T2 and stir sequence. I would like to highlight that necrosis cannot be picked up on the MRI. So it is the inflammation and the damage that is picked up. What is picked up more easily on the muscle MRI is the fibrofatty tissue whenever there is a chronic muscle damage. It is replaced by fibrofatty tissue, and this is picked up, and we use the T1 and the Dixon sequence for this. So we know that muscle MRI has got various applications in the current neuromuscular clinical practice. So it helps us choose the right muscle for the muscle biopsy. And very commonly that all of us come across with the pattern recognition, it helps us narrow down the possible diagnosis. Of late, there have been various muscle MRI papers suggesting the genetic correlation as well. It can be used as a good biomarker, especially in research settings and also whenever there is a disease-modifying therapy. Muscle MRI has also got very important utility in patient follow-up, and I'll be talking about this in today's talk, and also quite vital in planning care for our patients. So coming to just the texture or the type of muscle MRI changes, how that helps us narrow down a diagnosis or the possible pathology we are dealing with. If you've got a diffuse pattern of muscle involvement on the muscle MRI, then it's most likely muscular dystrophies. If there is a frosted glass appearance, then it is more likely like a congenital myopathy. If we've got a reticular pattern, then it suggests more of an underlying neurogenic disorder. Whereas we can also have some patchy involvement where you can have islands of normal muscle and islands of muscle having fibrofatty tissue replacement. They are more suggestive of neurogenic problems or VCP myopathy and glycogenosis. So these are some of the conditions that we should consider when we see patchy involvement. Something that they mentioned was, we usually come across asymmetric involvement in muscle MRI. Apart from FSHD, the other possible options are inclusion body myositis, and importantly, carriers of DMD, carriers of MTM. They also have asymmetric involvement in muscle MRI. So whenever we are seeing females having these kind of asymmetric involvement, this is one of the things to consider. And then in anoctamin 5 mutation and dysferminopathy. So when we sometimes do a whole body MRI to look for more of pattern recognition to be able to narrow down clinical diagnosis, then other muscles affected other than the leg muscles can sometimes help us with the diagnosis. So some of them are like in Pompe, OPMD, and in mitochondrial disorders, the tongue is affected, and this could sometimes be as a marker for the possible underlying etiology. The other possibilities are also ALS and musk myasthenia gravis. The tongue is affected in these conditions as well. We commonly come across the stir sequence whenever there is an increased stir changes that we see on the muscle MRI. Most commonly, we think of inflammatory myopathies as the cause, but we have to also bear in mind that there can be certain muscular dystrophies that can also come with increased stir sequences, stir hyperintensities. So that is FSHD, dysferlin, anoctamin 5, Pompe. And if whenever there is an acute denervation in an underlying neurogenic condition, we can have increased stir hyperintensities. The Newcastle group did a study this year, and I've published it in the Journal of Cachexia, Sarcopenia, and Muscle, where they have tried to develop a tool that can help us narrow down or give us the possible genetic mutations when we upload a muscle MRI. So what they did was they have got a pre-processing pipeline to standardize the MRI fat content across their data sets, and their model created helps identify certain disease-specific patterns. So they had used around 2,961 MRI samples from 21 genetically confirmed pediatric and adult neuromuscular conditions, and with that, if you would upload an MRI there with a particular pattern of muscle involvement, it can then give you 3 to 5 possible genetic muscle disease, which can have that kind of a pattern on the muscle MRI. So they found that the model, though the model balance accuracy was just around 64.8%, when they weighted the top 3 accuracy, it was almost 84.7%. And if within the top 5 genetic mutations, finding a possible diagnosis, the accuracy was up to 90.2%. So this is MyoGuide, www.myoguide.org. We can register and then can use this. So something that will be useful for our clinical practice. Muscle MRI for follow-up. We know that Duchenne is a quantitative measure that we use to identify changes in the fat content in the muscle. Now, measuring the fat content in the region of the muscle interest group over time or whenever we follow up patients can help us understand what is the rate of disease progression, and then also to understand the right point in time for intervention as well. So the changes in fat fraction correlates with the change in the muscle function and the functional outcome measures. And this is published in many of the papers as well. So this is one of the papers where they used quantitative muscle MRI to follow patients with late onset Pompe disease. And then if we look at the fat fractions that they have used, and serially when they have looked at the fat fraction going on increasing, though evidently, like if we just look at the muscle MRI, we might not be able to make out the changes. But when the fat fraction is calculated, there is even a 2 or 3% increase can be made out. And they have used this as one of the aids to decide if a patient should be started on a disease-modifying therapy or not. So what's more new in this is whenever they were using the Dixon method to estimate the fat fraction or the quantitative fat fraction in the muscle, it was a very manual process. Now they have come up with an automated process where they have used an AI-based deep learning tool to estimate the muscle fat fraction, like the quantitative fat fraction in the muscle. So in this particular technology, it automatically segments muscles in minutes, and it can annotate the fat fraction and also create a 3D reconstruction like this to understand which are the muscles affected and the differential pattern, and also give us the fat fraction. So this would be really useful for selecting therapies, especially where we don't see much of change in the functional outcome measures, but there is a change in the quality of the motor ability rather than the numbers on functional outcome measures. The next thing they touched upon was the changes in the water content or the water T2 time. So we know that the stir hyperintensity was quite commented about in the dysferlinopathy, the outcome study published in 2016. So they found that the stir sequences, the stir hyperintensities in dysferlinopathy was frequent in early or mildly affected muscles, and it often preceded the fatty replacement. Hence, it did serve as a good early marker of disease activity. So it decreased as the T1 fatty infiltration increases. So if you see stir sequence, stir hyperintensity is more in the fat or in the muscle interest group, and it's decreasing in the subsequent studies, and the fat fraction is increasing, it means that the disease is progressing at a faster rate. And it also represents the active myofiber damage. So this was the study that I was talking about, and published again in 2022. And they spoke that in dysferlinopathy, the higher water T2 at baseline significantly correlated with a greater decline in the functional test in 21 out of the 35 muscles, and was never associated with a slower decline in the disease. So this was one of the outcomes of the study. The most interesting bit that they spoke about was utility of spectroscopy in muscle MRI, like hydrogen spectroscopy, phosphorus spectroscopy, carbon spectroscopy, and recently the sodium MRI as well. So let's see what these are. The hydrogen spectroscopy, it is very useful to differentiate water from fat. And as the concept is that as the disease progresses, there is reduction in the water peak in the muscle, and there is an increase in the fat peak on the spectroscopy. Now, the hydrogen spectroscopy helps us detect and quantify what are the biochemical changes happening in different muscle tissues at the metabolic level beyond using your standard stir sequence or the T1 or Dixon. So it can help us understand what is biochemically happening in the muscle even before we see structural changes in the muscle on the muscle MRI. So that way it is quite useful to pick up early disease. The phosphorus spectroscopy is something interesting. We know that phosphorus is involved in many of the cell membrane or the mitochondrial metabolism in the muscle cells. So the understanding the utility and looking at the inorganic phosphorus peak, the phosphocreatine peak, ATP, and the phosphodiesterase peak can be very useful in mitochondrial muscle disorders because they are the markers of cell energy metabolism. Now, the phosphorus spectroscopy is also useful in muscle disorders, and they're used in research settings. Sometimes they're also useful to detect muscle damage because whenever there is a muscle damage, the pH becomes alkaline in the muscles involved, and there is an increased phospholipid turnover indicating a muscle membrane damage. And also there is muscle energy wasting, which causes the increase in the inorganic phosphorus. So when we do the muscle phosphorus 31 spectroscopy, you can see different peaks of phosphocreatine, phosphodiesterase, the ATP peak, and the inorganic phosphorus peak. And depending on which peak is higher than the control, we will be able to understand what is the metabolic change happening in the muscle. So, and the other interesting spectroscopy was the carbon spectroscopy, which is used in Pompe patients. And this is one of the abstracts from 2024 WMS, where they found the utility of carbon spectroscopy in Pompe's disease. So carbon is usually found in the older atoms in the muscle, and carbon spectroscopy is useful to detect glycogen in late onset Pompe disease. And it is also used as was used as a marker to see how the patient responds to therapies. And then recently we have had sodium MRIs. So the principle behind the sodium MRI is that it is helpful to pick up early disease even before we see structural changes in the MRI. The reason being, whenever there is a muscle damage, there is a change in the ion channels on the muscle membrane, because of which the intracellular sodium increases. So in healthy controls, we should not be seeing much of intracellular sodium, but whenever there is a muscle damage, the intracellular sodium rises, and this is used in the spectroscopy to look for active muscle damage. So this was one of the studies published this year in 2025, where they spoke about dysferlinopathy. They have compared, it's a small number, 6 patients against healthy controls. At baseline, they found that the dysferlinopathy patients showed higher water T2 and higher sodium concentrations than the healthy controls. These are dysferlin patients who do not have any muscle MRI changes as yet. So it's in them. And when they did an isometric exercise, and following the isometric exercise, they felt the muscle water T2 and the sodium returned to baseline following the increase, whereas they did not find any increase in the water T2 and the sodium in the patients with dysferlinopathy, and they did not see the decline as well. So they found that there is definitely a change in the sodium influx across the muscle membrane, and this could be used in sodium MRIs, especially in those with not having overt MRI changes as yet with the neuromuscular condition. So just to put it together and summarize, so we have new AI-based platforms which are becoming available to help with pattern recognition and aid in clinical diagnosis. The muscle fat fraction quantification is useful to understand the rate of disease progression or response to DMTs, and the spectroscopy has got a good scope to be used in clinical practice when it becomes available, especially to pick up changes in the muscle before we see any fibrofatty changes in the MRI. I'm happy to take any questions if there are any.
Okay, thank you very much, Dr. Ramya. We'll just, shall I go on to the final? I think we sort of stuck to time. And I'm just going to go on to the last talk, and then there's not so much questions. I'm hoping questions we can all mutually answer, because this was difficult for us to catch up with this. Shall I go on to the last talk? Is that okay? Shall I proceed?
Yes, ma'am.
Okay, sure.
Yeah.
So this is our part 1 in our effort, and I must confess that the part 1 has all been fully pediatric, because we are all pediatric based. But part 2, I promise, will be more adult. So Dr. Vishnu from AIMS and Dr. Urvi from the US, they've promised to do that. And of course, we have our Ms. Mahima, who will be doing, because we only have one orthotist who's interested and keen with this. So the 3 of them would be delivering the part 2 version of what we had in Vienna. There seem to be a lot of ideas, nice ideas. So I'm just jumping in. Some of it is similar to what Dr. Himashwata had said, but what fascinated me is the things in the way it was put. So the very first talk was the talk which Dr. Himashwata had mentioned. So this was Dr. Khan Hor, who worked in Nationwide. So Nationwide Hospital currently is the hub for all the new innovative gene therapies that are taking place in the world of Duchenne muscular dystrophy. So I'm given to understand that he is also a cardiologist who's in most centers, it is a neurologist or a neuromuscular physician who is the lead for Duchenne muscular dystrophy. But he is leading in the care of these children with Duchenne muscular dystrophy. And this was the outline of his really nice talk. And he also kept emphasizing so much on prevention. And what was also interesting was what Dr. Himashwata mentioned. In the Netherlands, they had a death of a 6-year-old who died in his sleep, which they could not explain. So Dr. Hor mentioned that if there's no scar, it's almost imperceptible. and that the moment the scar happens, it's a bit exponential. And the larger the scar, then it becomes much more, the velocity sort of hastens. So that's a tenfold increase every year, or 2.2%. And so then what he reminded us, that all these children would not have any of the conventional traditional signs of heart failure, the shortness of breath, the chronic wheezing. They don't have any of these things. They just have vague sensations. They've gotten used to their hearts slowly becoming like this. So it is a silent disease. So the onus is on us to try to pick it up. So even despite our best of our tries, and despite the fact that at least some percentage of our patients are able to afford cardiac MRI, about less than 20% of our patients are able to get access to cardiac MRI. So but what is important for us, it's irreversible. We know it is progressive, it is silent, and that I'm not going to go through this, which Dr. Himashwit has mentioned, that the late gadolinium enhancement is what gives us a lot more information, because early involvement is only the epicardial, it is not full thickness, and later the fibrofatty infiltration is into all the planes of the cardia, and so then that becomes a little too late, and that's when you have the established scar. So cardiomyopathy within the context of skeletal muscle involvement as well. That there are mutation-specific therapies available, there are innovative therapeutic approaches, and also understanding the genotype-phenotype. For this, we need to understand what is it that makes some children a bit better. Are there modifier genes? There must be some transactive variants, and how to correlate between phenotype, disease severity, and expressivity. Understanding this better might later become therapy and become newer therapeutic agents. They might become points where we can intervene. So we do know that what happens is myofiber damage. There are cycles of degeneration and regeneration. And what happens is they're exhausting their regenerative potential, and then entering into fibrosis, which is end stage, fibrofatty replacement. And progressive, by the time it's progressive weakness and functional loss, and we are still in the very early stages of regenerative medicine. So this has already been covered, so I shall not go through it. So once it becomes dilatory, it becomes a little bit too late. So the muscles start stretching, and then there's chamber dilation. So we use the ACE inhibitors and the angiotensin receptor blockers, mineralocorticoid receptor antagonists, and beta blockers. So this was news to us, the SGLT2I, but because it was a mixed audience, there were quite a few adult neurologists. So most of us, the oldest children that we have been dealing with are into their late 20s. That's also because I've not been working for longer than 14 years in here in India, are now entering their late 20s and early 30s. And so we are finding it difficult to manage that, and adult colleagues are helping us manage them. So the dapagliflozin, there were a few instances where patients could not tolerate. They had severe scoliosis, and that was also impinging on the cardiac function, but they were not able to undergo surgery. They had swallowing difficulties as well, and they found that this was something that they could live with, giving them dapagliflozin or empagliflozin. So cardiac females, as mentioned, follow the same pattern, but so they had a cohort of carrier mothers, about a third of them, whom they had studied for nearly a decade. So they still haven't come up with a protocol of whom to monitor, when to monitor, and how often to monitor. So prophylactic therapies prior to systolic dysfunction is expanding, as DMD-CM seems to be universal. So countries in Europe, some of the countries in Europe, including United Kingdom, mentioned that they had nearly 5 to 6 children who were well controlled otherwise from a cardiac muscle function perspective, who had succumbed in their sleep in their 15 to 16 years of age. So we are hopefully we are not seeing as much. When we compare practice, we seem to be giving preventatives much more. And once the preventatives stop working, then the cardiologists take over with their sacubitril and valsartan and all the other failure medications, heart failure medications. So this was from what Dr. Himashwita was mentioning. This is from our center that was published a few years ago by our lead cardiologist. So then I found some of the interventions, like Mitsugumin 53. They were speaking about this, the cytosolic calcium, that it aggregates around the mitochondria of skeletal muscle in the presence of reactive oxygen species, and this could promote plasma membrane. So this is a different, we're switching topics now. Promote plasma membrane. We're dealing with how dystrophy, the process of skeletal muscle dystrophy, or it could be applicable to both cardiac and skeletal. So mitsugumin 53 is expressed in both cardiac and skeletal muscles. And so this was so one of the papers that he spoke about from Zhao. And it was nice to notice that he said, if you're looking at only mutations in the DMD gene, the dystrophin restoration, exon skipping, we have golodirsen, eteplirsen, and many of the others. But again, what was interesting was one of the poster platform presentations, one of the early clinical trial updates was from Wave Pharma. Again, another form of 53 skipping. So they found that they had a better built backbone for their PMO. It made it more tolerable. It seemed to have better effects, and their dosing frequency is less frequent. It's fortnightly as opposed to the current weekly. So then the stop codon read-through, which we know about the atalurin and the still encoded other molecule. Then gene editing, such as we have Elevidys, but we also have other molecules of the RA, AAV, RH. That's the human recombinant MHCK7. So this was an interesting gene transfer therapy, which is being investigated for Duchenne, but now seems to be less promising for DMD and is now being studied more for dysferritinopathy. And gene editing still in the realm of not yet clearing ethics and not reaching yet to the field of skeletal neuromuscular disorders. So we're coming to this, where the next step, where the dysfunctional dystrophin is produced, so functional replacement, that is eutrophin upregulation and cell therapies. So this is still, again, this is another point where the gene therapy for that affects MHCK7 is also directing it. Then membrane repair. So membrane repair is where the previous molecule that we mentioned, the mitsugumin 53, works on this. So the membrane repair, both of the skeletal muscle and the cardiac muscle. So that also helps, leading to reduced calcium dysregulation. So how to improve calcium homeostasis? Streptomycin, we're still not using streptomycin, and a few other molecules, including rimeproride. And of course, your anti-inflammatories, corticosteroids, vamorolone, givinostat, tamoxifen, and edasalon next. So here, mislocalization, arginine. L-arginine was an interesting add here. And mitochondrial dysfunction, of course, L-arginine both in this place as well as at the mislocalization of nNOS. Antifibrotics, some of the MABs and immune-mediated therapies. And finally, we have loss of muscle function and bone homeostasis, because muscle and bone very much interact with each other, where bisphosphonates help. So this was a summary of Dr. Kaur's slide, and that was a study that he had alluded to, saying that of this, what is marked in purple is what is currently available in the market, which is the microdystrophin transfer. And Dr. Kaur was talking on behalf of Nippon Shinyaku Pharma. And ASOs, which is the exon skipping, commercially available exon skippings. So then came the next, one of the other interesting talks was from a biologist, professor, scientist from Ireland, who was telling us that maybe we are looking at things differently. We are maybe not looking at it right. So many of the limitations is studying biopsy. So they were talking more about, what about liquid biopsy? It's cheaper, which means we are not taking physical biopsies. Physical biopsies have a limitation of being quite expensive, invasive. This is less invasive. He said, study the multiomics. What is happening to the cell at different stages of regeneration, different types of cell. So studying multisystemic pathology of Duchenne muscular dystrophy, say what happens to the when the dystroglycan complex, dystrophin glycoprotein complex collapses, what happens to it? So laws of the sarcolemmal linkage. So what happens to the skeletal muscle primarily, and how to maybe looking at it better, and the body-wide changes, the neurological dysfunction, the varied amount of the big 10 problems, the cognitive impairments, the cardiac complications, the late onset dilated cardiomyopathy, the restrictive lung disease, and the metabolic impairments. We know that the bone abnormalities are not just related to corticosteroids. We do know that these children carry an inherent abnormality in their bone, and dystrophin is expressed in there, as well as endocrine abnormalities. So this is a very busy slide, and I must say I had to stare at it, and it was an early morning lecture, and it was really difficult. But going back and looking at that video again helped me understand at least some things, saying that please break it down. General skeletal muscle protein, he was basically trying to tell us, look at some of the protein biomarkers. And he was trying to say, this is how traditional skeletal muscle damage markers versus new markers using mass spectroscopy and proteomic surveys, and some pathological proteomic markers of myonecrosis. So something like the CA3, carbonic anhydrase isoform 3, the fatty acid binding protein, FABP3, and some of the other sarcomeric proteins, including isoforms of myosin light chain, myosin binding protein, troponin, and myomycin. So this is from Professor Ollendijk from Kildare, Ireland. So biomarker signature of skeletal muscle damage versus how do we utilize this to see how muscle is damaged and how they recover. And we know the stages of progressive myonecrosis. So that was his conclusion side, saying that can we get, and the take home was invasive muscle biopsy versus cheaper, less invasive liquid biopsy, and possibility of its implications on sampling and cost effectiveness. So then we went to the theme. A large theme for this conference seemed to have been the multisystemic nature of many of these disorders which many of us have spent our lifetime fighting. So to understand that we are a neurologist or a neuromuscular specialist, an adult practitioner or a pediatric practitioner or a geneticist, we've thought SMA, and SMA is anterior horn cell, and then to find out that no, not really. It is not just that. It is other things as well. So Professor Jan Kirchner spoke about the organ-specific deficiency, and he himself, being a pediatric neurologist, he himself confessed at the beginning itself, I'm uncomfortable doing this, but this is important. So organ-specific deficiency of SMN protein in humans. What happens? So the pathological hallmark is motor neuron loss, which we all know. But that has implications to neuromuscular junction. People like Dr. Radhika Manohar and those who follow their lifetime looking at the pathways and changes across the neuromuscular junction, these become important. Neuromuscular junction and end plate myopathy, or in the end, what happens to the muscle. This also changes to proprioceptive sensory neurotransmission. We do know that there's abnormal fatty acid metabolism and hypolipoproteinemias. There is inappropriate glucose metabolism and pancreatic defects. And there's, in the very young, now that we are modifying the natural history, we're seeing cardiac defects in severe SMA, and we are seeing vascular defects in severe SMA as well. So this is a very nice paper that they quoted from, which was a systematic literature review of 72 different studies from Dr. Van der Paul. And this was done by, this was quoted by Dr. Krishna in his talk. 72 studies, 264 SMA affected children with cardiac pathology. So it is 264 children with cardiac pathology. And they found that interventricular septum defects were also seen in mice. And the red area that is marked, these seem to be the areas where the defects are congregating in. So in order of recurrence, in order of how common they are, they've grouped them as from most common to less common. So abnormalities of position and connection versus all the others. So then this is another molecule that I found very interesting. So this is a latent myostatin inhibitor. A company called Scholar Rock, this was taken from their website, but this was this is what was studied, and this is what was published. Unpublished data was presented during this WMS. So the apitegromab, which is the latent myostatin inhibitor, seems to work very well. They had studied them for a few years. They had given this to children and young people who had already received at least one or more disease-modifying therapy for SMA. And this is the TOPAZ study. They've got this is phase 2, but they've done beyond the phase 3 studies this time when they reported. And they did it for both type 2 and type 3. They found that the ceiling effect, so you've got children we've intervened because these medications, the disease-modifying therapies, nusinersen, risdiplam, and gene therapy were available only now. So when we started intervening in these children, many of them were not pre-symptomatic. But once intervention happened, there was an improvement and then a ceiling. Even in those that had achieved ceiling, giving apitegromab seemed to give some gains motorically and stamina-wise and in quality of life. And that gains seemed to come from the muscle and not the anterior horn cell. But they also mentioned that when they studied apitegromab individually as a standalone therapy, it did not work. It seems to work only as an adjunct. This might be useful for us because now that we have the cheaper Indian-made molecule of risdiplam, we might be able to give this to our children in the future. So some more insights from the multi-system involvement. So the other multi-system involvement of the single gene disorders like FSHD and myotonic dystrophy, all our adult colleagues will do in the next part talk next month. So some for SMN, motor specific, we know that there is SMN deficiency produces severe motor impairment. We also know that this specific deficiency if there is a severe SMN deficiency in the muscle, you see a dystrophic phenotype. This which is rescued only if the presence of a minimum of 2 SMN2 copies. So nature sort of wipes out anybody without, if you have 0 SMN and 0 SMN2 as well, we don't get to see those children, those individuals. So they know, at least from those conditions where they've had to see them or they've got biopsies, they know from them that it is a dystrophic phenotype, which is rescued. So we do know that muscle per se, not just the anterior horn cell, because that is an entire motor unit, is affected. So liver specific, this seems to be lethal if there is no SMN2 copies. So this lethal phenotype is also rescued by SMN2. We do know that it is mostly normal, but liver has, we are increasingly becoming aware that liver has some involvements, especially the fatty acid oxidation defect and other functions involving the liver. And then there's a threshold for, so it seems to be tissue specific, there's a threshold for SMN knockout, beyond which the tissue doesn't survive or has serious problems. So complete SMN knockout in any organ is detrimental, but maybe a small amount of level that is produced by the SMN2 analog or paralog gene might be sufficient. So this has implications for drug treatment in SMA. So we have the gene therapy, we have the small molecules, we have the antisense oligonucleotide, the risankizumab and the nusinersen, but we don't know we know that the long-term expression of gene therapy is only in the post-mitotic tissues. We know that the small molecule orally administered drug addresses all tissues, and the intrathecal nusinersen only addresses SMN increase in the CNS. So studying these, there are some questions that come up which might make it easier for us to help improve the lives of these affected individuals. Are there extra motor neuron manifestation that require systemic treatment? Does the systemic treatment lead to better outcomes by addressing these? And do patients manifest these extra anterior horn cell manifestation after focal treatment? So that these are certain questions that are facing us. So this is, we're coming to the end of it. This is presented by, this I found very interesting. This was on the final day by Professor Eugenio Mercury. So he had presented saying nusinersen, the nurture study. So we know the nurture study where in nurture they showed that this is the preceding study in nusinersen, that they were pre-symptomatic, that these individuals they fared much better than the cherish where they were already symptomatic. These were individuals, young people with 2 or 3 copies, but they did not have any symptoms. And the devote was where the nusinersen higher dose was given. So these were individuals who had already been for a few years, 4-5 years, they were on nusinersen, stable dose, finished the loading dose and on maintenance dose of 4 monthly maintenance dose, and they had reached their ceiling. When they were given 50 milligrams, there was no improvement. They all improved, had a little bit of decrement, which sort of, and then stabilized there. So every 4 months, the maintenance is 12 milligrams, which would work up to 36 milligrams because they get 3 doses in 1 year. As opposed to that, when they gave them 50 milligrams as a one-off dose once a year, they found that there was benefit. So this was Biogen announcing it, saying that this might have significant benefit, meaning the top line has been overshot. So this might have, our patients might be happier because it might mean that it is less hospitalization and less intrathecal, less invasive administration of medication. So again, coming to the end, this is something we found very interesting because we are struggling with cough assist. So somebody in Clinic Favoritin from Vienna, they had produced this abstract which had done an indigenous kind of cough assist, which was externally done, and they were using a foot pedal trying to do this. So I'm hoping that there will be other scientists and other people who come up even in our own country, we can come up with models which might be useful for our children, because this is the only way of sustainable care. And this is some interesting things. So this is, I have to confess, this is work done by my friend. One of her students, her PhD students, presented this gene therapy for brain phenotype in mice. They injected AAV vectors which deliver the shortened dystrophin, microdystrophin, directly into the brain through an intracranial injection into neonatal mice into the intraventricular system. And they found there was improved neurobehavioral phenotypes such as anxiety. And but there was a limitation. It did not seem to penetrate the cerebellum. I'm assuming they had sacrificed the mice and looked at the cerebellum for expression. So this was from UCL and under Professor Joe and Professor Montoni. So some more final few lines from Professor John Wissing, gene transfer for FKRP, LGMD R9, the ATA 100, and it seems to be people are tolerating the dose escalation, and there is marked decrease in CPK and some motor velocities. Clinically, they seem to have reduced clamps and myalgia. And on biopsy at 3 months, there was reduced central nuclear pathology. And there was also, this is the final slide, there was also something about BIN1 gene replacement in mice. So central nuclear myopathies, where there is weakness and organelle misplacement within the myofibers. So most are caused by mutations in proteins involved in membrane remodeling, like amplifysin 2. So there was change in biopsy in the muscle studied. So something about late onset SMA and mitochondria, looking at metformin as a potential therapeutic agent to intervene between the interactions between astrocytes and microglia. Sorry. So that's it.